Good morning again to anyone that may have signed on in the last few minutes. I'm Dr. Amanda Smith, an Education Work Group Co-Chair for the Watch Coalition. Thank you for joining us at our virtual Watch Wellness Workshop. Please sign in to today's event either by using the QR code on the CEU slides, or there is a link in the chat box that Emily placed at the very beginning. If you can scroll up to that, or maybe she will pop it in there again so that everyone can get signed in for today's event. We'll begin promptly at 11 a.m., so just a few minutes. So after you sign in, please update your display name by clicking on the Participants button, hovering over your name, clicking Rename, typing your first and last name and organization, then clicking OK. I've kind of modeled that for you guys in my chat box, or in my video, sorry. So in order to help networking, please share in the chat box your name, the organization you are with, and the primary population you serve. Also, please remember to keep yourself muted unless you have something to share. And our speakers would love to see you, but video is not required. You can also use the chat feature to ask questions. So again, we'll begin here in just a minute or so. In the meantime, if you guys could get signed in using either the QR code or the link in the chat, that would be great. Thank you. All right, it's 11 o'clock. So we'll now get started. Please be aware that this session will be recorded and made available through website and social media links to inform and educate the public on this topic. Throughout today's program, our speakers may ask you to unmute to ask or answer questions. Keeping that in mind, if you choose to participate in an identifiable way, you acknowledge that your image and or name will be recorded and are authorizing the use of your information in the recording as described. You have no obligation to appear or speak in the recording. You can turn off your video and participate under an alias should you wish to remain anonymous. The recording of today's workshop is protected by copyright law and is not to be copied. If you feel comfortable doing so, please turn on your video at this time. So welcome on behalf of the Watch Alliance Watch Alliance for Total Children's Health of Denton County. I'm Dr. Amanda Smith, an Education Work Group Co-Chair for the Watch Coalition. It's our goal to work together to organize opportunities for professionals and community members to learn about specific topics related to children's mental health and to learn about the resources available in our community. We have many people to thank for working collaboratively to put this event together. We'd like to thank the members of the Watch Coalition for planning and thinking through the program, Cook Children's for providing CEUs, and if you have attended any of our previous events, thank you for providing feedback. We planned this program with you in mind. We'd also like to thank each of our speakers for giving their time and sharing their expertise with us today. With their permission, we will post the slides from today on the Center for Community Health website. We also have a few housekeeping details. We invite you to engage with the speakers and other attendees in the chat box. You can talk with the group as a whole or one-on-one by clicking on the button next to the To field in the chat feature. This is located just above where you type your message. We will also keep the event open for 15 minutes after the event, from 2 to 2:15 this afternoon, so you can continue networking, ask questions, and share information about your organization in the chat box. Today we will be discussing suicidal ideation, cultivating support strategies for children and youth. We will learn about current research on suicidality, crisis management, interventions, and creating trauma-informed culture of unconditional support. An evaluation link for today's event will be shared at the end of the program. All are encouraged to complete the evaluation, and it is required to receive continuing education credit. So if you want CEUs for today, you do have to complete the evaluation. So for your convenience, we've created an event packet for you to use as you follow along with today's presentations. And that should have been sent out to you in the invite that you got with the link for today's workshop. So you should have received an email with the link to the event packet. If you did not receive this, please let us know in the chat with your email and we can send it to you. So if you need CEUs or a certificate of attendance, please make sure you have signed in. So later today, those who have signed in will receive an email with a link to fill out the online evaluation about today's workshop, or there will be time at the end to complete the evaluation. You can print your certificate later when it's convenient for you. Again, just as a reminder to sign in, there's a QR code in the slides, and there's also a link in the top of the chat. So today's speakers have no conflicts of interest to report regarding today's presentation. So if she is ready, I would now like to introduce Lindsay Schaefer, a member of the Watch Coalition and part of the Education Committee. She would like to talk about the value we place on collaboration. Thank you, Lindsay.
Thank you, Dr. Smith. Thank you, everyone, for joining us today. We are so excited to have you here for our Watch Wellness Workshop. Before introducing our first speaker, I would like to share with you about why we do what we do as the Watch Coalition. In 2011, the Watch Coalition was formed by a group of dedicated organizations and individuals who were committed to improving the total wellness of children and families in Denton County. Our vision at the Coalition is because every child deserves hope. The Denton County community dedicates its unified resources to equip our children to reach their full potential mentally, physically, and socially to achieve their maximum personal success. One key strategy to achieve this goal is to maintain a diverse and active membership. We are a collaboration of both public and private organizations and individuals who are invested in the total wellness of Denton County's children. Our shared passion of improving children's mental health is the guidepost that we base all of our choices as a coalition. We understand the value of working together to improve children's mental health, and we truly are grateful for all of our members, volunteers, partners, and allies. We regularly work to strengthen the network of mental health professionals by offering educational and networking opportunities related to children's mental health, like this workshop. We also invite the parents in our community who feel they might benefit from attending these workshops. If you are a parent attending today's workshop, thank you for coming, and please feel free to visit the C4CH website, where you will find resources, information about community events, materials from past workshops, and much more. I would like to thank Dr. Amanda Smith and Rebecca DePeo-Christner, the Watch Education Work Group co-chairs, and the members of the Education Work Group for their work in planning this workshop. It takes so much effort, and we are so grateful. I can see by all who came today that this is a much needed topic to discuss. Again, thank you all so much for being here and for spending time at this workshop today. I am now so pleased to introduce our first speaker, Rebecca DePeo-Christner. Rebecca DePeo-Christner, LPCS, LCDC, NCC, is the Coordinator of Social Emotional Learning for Denton ISD. Rebecca received her bachelor's degree in psychology from the University of North Texas. Upon completion of her undergraduate degree, she pursued her master's in marriage and family therapy from Antioch University in Seattle, Washington. Rebecca has been an LPC supervisor for 12 years and has supported 14 counselors seeking to obtain their LPC. Rebecca has 24 years in public education and has supported both general and special education. Outside of Denton ISD, Rebecca has been providing therapy at the Counseling Center of Denton for the past 11 years as also an adjunct professor at Texas Women's University. Rebecca recently was trained as a trust-based relational intervention practitioner by the Karen Purvis Institute in Child Development at Texas Christian University. Rebecca, thank you so much for joining us today.
Thank you, Lindsay. I appreciate it. Well, thank you guys for having me today. I'm going to talk about the current research regarding suicide rates across the United States. So what we know right now is that from 2000 to 2018, suicide rates increased by 37%. What we did see is that between 2018 and 2019, there was actually a minor decline in suicide rates. They had really speculated it was a result of prevention and intervention that was happening that caused that decline. We also saw the decline happening on the first onset of the pandemic, and that was the first decline in suicide rates in the past 20 years. So that was pretty significant that we actually saw a little bit of a decline. What they speculate what was happening with the onset of the pandemic was that, people were kind of pulling together in March of 2020 for the first few months. News stories were focusing on little victories and heartwarming tales of communities kind of coming together. Additionally, children weren't necessarily in school where they were faced with maybe some bullying, and employees weren't necessarily in maybe some toxic work environments. So there was definitely some things that were happening that maybe contributed to that continued decline during the pandemic. Additionally, we knew that therapists were actually becoming more available through the onset of more telehealth providers. So what we do know, though, is that there's 15 deaths for every 100,000 people by suicide. And so when you look at the numbers for 2022, it was the largest number of suicides that have happened. And you're roughly looking at about 50,000 lives that were lost due to intentional self-harm. And so we look at the numbers. For every suicide death, there were about 3 hospitalizations for self-harm, 8 emergency department visits related to suicide, 38 self-reported suicide attempts in the past year, and 365 people who seriously considered suicide in the past year. So those are pretty significant numbers. And if you look at it from a whole, that's 12.3 million adults seriously thought about suicide in this country. 3.5 million adults made a plan. And then 1.7 million adults attempted suicide, which account for 1 death every 11 minutes. So what we know about suicide rates differ by age. We know that when you look at the age, that 26% of high school students are more likely that identify as lesbian, gay, or bisexual reporting suicide attempts in the past 12 months. And so if you look at this, it's youth and young adults aged 10 to 24 years account for 15% of all suicides. And suicide is the second leading cause of death for this age group. It's also increased by 52% between 2000 and 2021. And girls and young women are more likely at high risk for emergency department visit rates and twice as more likely than boys and young men. And in 2021, 9% of high school students reported attempting suicide in the past 12 months. Additionally, we know that aged adults 35 to 64 years old account for 46% of all suicides in the United States. That's the 8th leading cause of death for this age group. And lastly, adults 75 and older have one of the highest suicide rates at 20 per 100,000 individuals. So what we know is that suicide rate is higher among people that identify as lesbian, gay, or bisexual, and they're 5 times more likely than heterosexual students to contemplate suicide. We also know that veterans, it's the second leading cause of death for under 45 years old, and that veterans have an adjusted suicide rate of 57% compared to non-veteran U.S. adult population. And that we also know that suicide rates are highest among non-Hispanic adult Indian and Alaska Native people, as well as non-Hispanic white people. And then lastly, we know that adults with disabilities are 3 times more likely to have suicide ideations in the past month compared to people without disabilities. So we do know that suicide rates differ by industry and occupation. The 3 top industries and occupations that are most at risk for suicide is construction and extraction, installation, maintenance and repair, and then art, design, entertainment, sports, and media. And we know that half of all suicides in 2022 involved a gun. And 44% of Americans report living in a gun within their home. And so we do know that recent gun-related suicides were really the driving factor behind the rise in suicide rates overall. And what we do know is that white men, along with those at 75 or older, are more at risk by suicide by gun in 2021. And then 55% of individuals with ideation in a plan attempt suicide. That differs from individuals that just have ideations. They're just 15% chance of making an attempt. And 1 in 5 Americans describe their mental health status as fair or poor. And 1 in 5 adults say they often or always feel depressed, lonely within that past year. And so what they're identifying is that when they look at specific populations, they're definitely more at risk for not feeling mentally healthy. And that would include the LGBTQ, as well as adults under the age of 30, as well as incomes that are less than $40,000. And when they surveyed through the National Alliance on Mental Health, it found that 9 out of 10 in the United States believe that we're in a mental health crisis at this point. And I think the numbers definitely support that. And with the onset of the 988 Suicide and Crisis Lifeline, what they found is that within the first year, there were 5 million calls, texts, and online chats through that 988 system. We also knew that 1/5 of those were veterans in our military. And despite having such a high volume of calls, 80% really report being unfamiliar about the new 988 suicide and crisis line. So that's a lot of volume without obviously a lot of individuals not even knowing that this is in existence. And interesting facts about COVID is what they're finding out is that COVID may cause dysregulation of neurotransmitters and the dysfunction of large cortical networks and brain structures, which actually they're finding out that it may be linked to some suicide ideations in patients. And what they're also finding out is that with long COVID, which can range from about 200 different symptoms, and those symptoms can be exhaustion, cognitive impairment, pain, fever. According to them, that 15% of these patients are having symptoms that are persisting more than a year. And out of that, 44% of them are actually have considered suicide as a result of those symptoms from long COVID. And so just kind of going through all these things that we've kind of discussed is just the 5 risk factors for increasing suicide behavior. We obviously know gender certainly plays a part. Males are more likely to complete suicide. We also know that our LGBTQ population is certainly at risk. We certainly know that there's job factors such as occupation, low job security, low pay, job stress that can contribute to that as well. Certainly mental health struggles such as depression. And we also know that there has been an increase in alcohol use since the pandemic. And as a result, people that are drinking heavily are 7 times more likely to attempt suicide. And then lastly, obviously, that access to a gun, which account to the increase in suicide attempts throughout the country. And then just briefly going on non-suicidal self-injury, one of the things that, just to distinguish between the two is that it's really the intention. Obviously, non-suicide self-injury is really just causing harm to their self, whereas a suicide attempt is really trying to end one's life. And we know that 18% of secondary students are engaging in NSSI behavior. And so there's just really 5 forms of interpersonal motivations for having NSSI behavior. Obviously, releasing bottled up feelings of just self-punishment, turning aggression inward, sensitizing oneself, and just attaining a sense of control. And then 5 criteria that increase risk for NSSI behavior. We know that obviously mental health struggles contribute to that. We certainly know that adverse childhood experiences would certainly have an impact, as well as bullying and certainly behavioral problems. We also know that females were twice as likely to report NSSI in the past year compared to males. And then risk factors for NSI linked to suicide behavior. The first one is just more severe forms of NSSI. That could be cutting, carving, burning. So doing just more severe forms of it. We also just know the frequency of how often that they're doing that NSSI self-harm behavior. And then lastly, we know that just using multiple methods certainly increases that link to suicide behavior. So hopefully that gives you some just current research and obviously populations that we certainly need to be watchful for regarding suicide ideation and certainly increasing the risk for suicide attempts. And I appreciate you guys taking the time to listen to all this, lots of data. So thank you.
Rebecca, thank you so much for sharing that valuable information. We will use the next 5 minutes to take any questions that anyone has. So if you do have a question for Rebecca, please feel free to unmute yourself or put your question in the chat box. And then we will, after the next 5 minutes, move on to our next topic of discussion. Are there any questions for Rebecca?
I have a question. I know at one point there was a lot of research saying that, or maybe not research, but people were saying that women might have attempted more, but men completed more often. And then I've heard that that has shifted recently. So I was just wondering where we were at on that.
At least in the information that I was kind of finding out, I hadn't seen necessarily that shift yet. I'm sure that there's going to be a lot more research that's going to come out in the next few years, with some of the data collection, because there was a decline from 2018 to 2020. I think they're still kind of examining that information and that data. At least that's what I've seen in all the research that I've done. But that will be interesting. I mean, it's interesting that we were on a decline before the pandemic. And now we're definitely shifting upward with the most amount of suicides in 2022.
Thank you.
Any other questions for Rebecca? Okay. I don't see anything in the chat. Rebecca, thank you so much for your time and for sharing that.
It looks like someone is trying to speak, but they might be muted. I don't know. It looks like Tam Long.
Go right
If you want to unmute yourself.
Okay. I was just curious, when you're talking about self-harm, what are some the youngest ages that you've encountered? I have a youth I work with that's 8, and it just feels like talking to an 8-year-old is different than talking with a 16-year-old. And I was just curious what your thoughts were on that.
Yeah, I mean, it's definitely going to be a different conversation, certainly. I know in the school system, we see it as young as very early elementary students that are, self-harming. I think a lot of it, it comes from, we know that anxiety is the number one diagnosable disorder in children. I think a lot of it comes from that anxiety. I don't even know if they know that they're maybe scratching themselves or picking at themselves and doing some of those behaviors. But I definitely think it's a release of these emotions that they're just not capable yet of maybe being able to explore and deal with. And so we're trying to give them that language for it. There's just so much social regression that's happened as a result of the pandemic. But we've seen it very early on with little kids. I've seen a lot more, at least recently, some trichotillomania where kids are pulling out their hair, eyebrows, and things like that.
Thank you.
Yes, I would like to add that I think that next year the statistics might go up because all of this separation of the families and immigration is going to have an impact on the statistics. There have been a lot of separation of the families. There have been a lot of abuse and neglect, in the border with minors and so forth. So unfortunately, I think that the statistics, they're going to go up for next year.
Yeah, I imagine that would be certain, Joseph, just considering the trauma that some of these families are experiencing.
Yes.
Well, thank you all for engaging and asking questions. And again, Rebecca, thank you so much for your time and sharing with us this morning. I am going to continue moving us along. So I'm going to introduce our next speaker. Catherine Pike is the program manager of psychiatric triage at the Denton County MHMR and has been with the center since 2021. She earned her Bachelor of Science degree in Rehabilitation Studies with a minor in Addiction Studies at the University of North Texas and is currently enrolled in the Masters of Rehabilitation Counseling program with a projected graduation date of December 2024. Catherine has a passion for helping individuals in the community who experience and struggle with, I have to turn my page, with mental health disorders, homelessness, and substance use disorders. To further her education, she has completed the 40-hour Training for Trainers course in Applied Suicide Intervention Skills Training, the ASSIST course, which allows Catherine to be a certified ASSIST trainer. She is also Child and Adolescent Needs and Strengths, which is called CANS, and Adult Needs and Strengths Assessment, INSA certified. Thank you so much for joining us today, Catherine.
Thank you for having me. I really appreciate the opportunity to speak about something I'm very passionate about. So let me share my screen. All right, so we are a nonprofit organization. We are a unit of the local government administered by a 9-member board of trustees, which are appointed by the Denton County Commissioners Court. We are contract providers for Texas Health and Human Services, and we are a certified community behavioral health clinic. So our mission is to enhance the quality of life of the individuals served and their family members. And what services do we offer? So we have a plethora of services that we offer. We offer ACT team, which is our assertive community treatment. We offer case management, child and adolescent services from the ages of 3 to 17. Compass is our first episode of psychosis program. We have a crisis hotline, our mobile crisis outreach team, which go out into the community to do those risk of harm assessments and meet those clients in their environment. We also have hospital liaisons, which work with our state hospitals as well as UBH and our contracted hospitals to make sure that we are doing continuity of care with the individuals after they come out of a stay. So we do aftercares, we get them enrolled in services. We have intake and referrals, so people can come in off the street and sign up for our services and receive those. We also have a pharmacy now, which is great. We do, oops, let me go back out. It's going forward. See, I told you all I was not technologically inclined. We also have a psychiatric triage center. We are a 24-hour facility where people can walk in. Sometimes they're brought in by the community for those risk of harm assessments to see what their needs are. So the next slide was, what do you need to have, or what is the criteria for becoming a client? So you must be a resident of Denton County. You must have a diagnosable mental illness. The age requirement, you have to be 3 years or older. You must have Medicaid or be uninsured. We are accepting some private insurances now. I think we're still in the beginning phases of that. And you must complete an intake through our main office, which is Denton County MHMR. So how can an intake be completed? And this is when someone is first coming into services with us. They can call the hotline. We also have walk-in hours between 8 and 5 p.m. Monday through Friday. When they call the hotline, they do have to let them know that they're calling for an intake and not a crisis. And that number, if you want to write this down, is good to pass out. It's 1-800-762-0157. And that number is available 24/7 as well. So they can call that at any time for crisis. And I believe to schedule the appointment, it does have to be through business hours. So, right. So what is considered a crisis? A crisis is a stressful situation or set of events that are perceived or experienced as intolerable and unsolvable because the individual's customary coping strategies and problem-solving skills are exceeded. So in a crisis, an appropriate coping response is unknown, but in an emergency, it can readily be implemented. Denton County MHMR defines a crisis as someone who has thoughts of suicide, homicide, and or has deteriorated to the point where they are at risk of harm to themselves or others. And then we move specifically for youth. Some of the warning signs that we see in youth who are experiencing those suicidal thoughts is they become disinterested in their favorite extracurricular activities. They have problems performing at school. They lose interest in, hobbies, talking to friends. You might see an increase in substance use. So they might start drinking or, experimenting with drugs, behavioral problems, risk-taking behaviors. They might be hanging out with a new group of friends that they have just met online, things like that, or talking to people online. Withdrawing from family and friends. You might notice sleep changes in their eating habits. They might begin to neglect their hygiene or appearance. Sometimes teenagers, they can be very involved in how they look. So you might notice that they're not taking showers anymore. They're not, getting ready to go to school. They might be in emotional distress. They might complain, which might cause physical complaints. So they might talk about oh, my joints hurt, aching, things like that. Hard time concentrating, declining grades, and maybe starting bullying or being bullied, loss of interest in schoolwork. So there's many different signs. Do all those signs mean that someone is suicidal? No, but those are some good signs to watch for. They might give you verbal cues. So they might say, I don't want to be a bother anymore. I don't want to be a trouble to anyone. You might notice them giving away items or just not caring about items that they used to care about. Writing notes. If you notice a lot of journal writing, it might be a good idea to look in the journals and see what they're writing. They might have extreme mood swings. unhealthy relationships, and those can be they're hanging out with a new group of friends that they had not previously hung out with. They might be talking to people online more, engaging in those unhealthy friendships. They might suddenly become cheerful after a period of depression, and that might mean that they have already made a decision to act on those thoughts, almost like they're expressing, like, I guess, relief from having come to a decision. They might refuse help, saying, like, I'm beyond help, or it doesn't matter anymore. They might complain about being a bad person or feeling rotten inside. You might hear them make statements about hopelessness, helplessness, or just not feeling worthy. So they might say things like, nobody cares about me. It doesn't matter. My opinion doesn't matter. Things that they might have used to participate in, they might just not be doing that anymore. They might not tolerate praise or reward, be like, I don't deserve it. You might actually hear them talking about suicide plans. Sometimes the kids will voice it and say that. So they might talk about it to their friends. They might talk about it to you, parents, things like that. They might be exhibiting impulsivity, such as violent actions or rebellious behavior, or even running away. Some of the questions that we ask are, have they been engaging in starting fires or running away? Those are the two ones that we ask. As well, we ask a bunch of other questions, but those are the two ones that we specifically ask for youth. Are they using social media to, post things? That's Twitter, Facebook, are big places where people will post. They might post things like, I'm giving up, or, you might just see some unnerving comments, statements that they're writing on there. So 4 out of 5 teen suicide attempts have been preceded by clear warning signs. And then how to tell what the difference between passive thoughts of death versus suicidal thoughts. So sometimes, our youth will make expressions such as, like, I wish I could just go to sleep, or I don't want to be here anymore. And that might be taken as a suicidal thought. There is actually a difference. And before I started working here, I did not know the difference either. But a passive thought of death is that you're just not wanting to be here. So if something happened to you, you'd be okay with it, but they aren't actually doing anything to end their lives. They don't have a plan. They're not wanting to act on it. They just feel hopeless about the situation. Whereas suicidal thought is an active thought of wanting to kill themselves. They might not have a plan. They might not have intent. They might not even have a method, but they have that thought of, I want to kill myself. And they might make statements like, it would be so easy to end my life. And they might give you, an exact method or plan. So even though, and I think a lot of people get confused on the passive thoughts of death and the suicidal thoughts, because even if there's a thought of, I'm going to kill myself, that's still a suicidal thought. They don't have to have a plan, method, or intent. And those passive thoughts are different because they might want to die, but they are not thinking about killing themselves. I hope that makes sense. And so these are just some definitions about what suicide is. It's caused by suicide is self-directed injuries, injurious behavior with any intent to die as a result of the behavior. A suicide attempt is a non-fatal, self-directed, potentially injurious behavior with any intent to die as a result of the behavior. A suicide attempt may or may not result in injury. And then you have your self-injurious behavior, also called self-harm, is the act of deliberately harming your own body, such as cutting or burning yourself. It's typically not meant as a suicide attempt. Rather, self-injury, it's a way for people to cope with emotional pain or intense anger and frustration. So young people are much more likely to use firearms, suffocation, and poisoning than any other methods of suicide. Children 14 and under are more likely to use suffocation. 90% of young children who complete suicide have some type of mental health disorder. And then this is an example of our CSSRS. It's the Columbia Suicide Severity Risk Screening. And there is an adult and a children one. So we do ask these questions. Have you had wished or wanted to be dead in the last month? Have you actually had thoughts about killing yourself? So if they answer yes to the first two, then we consider it high risk. If they don't, we kind of go from there and figure out, what other steps they need, if they actually need to have a screening and things like that. So that's just kind of an example of the forms and some of the questions that we ask. When we do a risk of harm assessment, we use the case approach when we're asking about those things. So some of the information that we gather when we complete those risk of harm assessments is we're asking, have they had thoughts first and foremost? Are they currently having thoughts? When the last time they were having thoughts were? How many attempts they've had in their life? What happened when the attempt occurred? It's important to us to find out, were they alone? What are their patterns? Did they attempt while they were at home? Did they attempt while they were at school? That way, when we're safety planning, we have a more comprehensive idea of these are some of the areas where, if they're at school or their parents work, things like that, we need to, put some safety plans in there for when they're at home. We also ask about their most lethal attempt. And so that would be did they need medical attention? So we would consider that probably for, anyone, if they're getting medical attention, it was probably a pretty lethal attempt. And then we want to know, if they took pills, how many pills, what kind of pills, the reason that they attempted, was there a triggering event? Are there things going on in their home life, school? What's causing these thoughts? Were drugs or alcohol involved? What was the outcome of the attempt? Did they tell anyone about it? Did they get help after that? Did they have inpatient treatment? And were those attempts planned or impulsive? So all of this gives us just a general idea of how the client is reacting to their environment, how, what steps we need to be aware of, things like that. We also ask them their moods. And this is another kind of lengthy section when we're doing the assessment. We're asking, do they feel that their life has hope? Do they feel they have purpose? Do they feel trapped in their situation? Have they been engaging in any risky behaviors? Have they been diagnosed with anxiety, depression? Have they have anger issues? And how often they're having these thoughts. So we can kind of get a pattern and see, when did these things start? How can we help with them? Are they already getting help with these issues? Then we also do safety planning. Anyone that we screen, we like to come up with goals, coping strategies. So we complete safety plans with every individual that we screen, kids, adults. And so it's the Barbara Stanley safety plan. So we'll ask them to identify what their warning signs are. So it's really a collaboration between the client and the screener, the assessor, so that the client can maybe get a clear idea of these are some of my warning signs, symptoms. We write those down. What are some things that they can do on their own without having to get outside help? Because sometimes, the people who are being screened, the kids, they're not going to necessarily have anyone who is around them who can help them, kind of calm down from that situation. So we ask them to come up with some internal coping strategies, whether that's like listening to music, drawing, things like that, things they can do on their own. And then we have them provide a list of people who can provide distraction or locations that they can go to that can help provide distraction. And then we ask for individuals that they can contact and ask for help. So friends, family members, like even teachers, counselors. And then we also list out professionals and agencies where they can contact in a crisis. So we always like to provide our information as well as the 988 number, our hotline, and then police as well, and the nearest hospital in case they feel they just can't keep themselves safe and they need to help right then and there. And then we also list out their protective factors and strengths, and then we provide support for that. So some protective factors might be their family, friends. We've had people list like pets as protective factors. So it can really be anything that is helping them to turn away from suicide. And then we also, no, that's too far. We also do phone follow-ups and 24-hour follow-ups. During the safety plan, we talk about access to means. So we're finding out what their methods are. So if they are reporting that they're going to overdose or that's their plan, we find out like who can secure the medications in the home. Can they be locked up? Same with like guns. Is there a safe in the home? If not, we do have gun locks that were provided to us through different police agencies. And so we can provide those to staff or to clients, not staff. Well, we can provide them to staff too, but clients as well. So do they have the ability to purchase? Do they have the ability or access to get in touch, like get a hold of their means? So if there is a plan to walk into traffic, how can we help with that? So that might be, when we do that, we have an ensure safety. So we have someone with the person for the 24 hours until they have their follow-up appointment. It's really just taking all steps and measures to make sure that the individual is safe, and finding ways to do that. So what can Denton County MHMR do for someone in crisis? So we can provide the crisis hotline where people can call. The hotline staff will refer them to either our mobile crisis team if they feel they need an assessment, or they'll provide referrals for intake. Or they'll have them come into our physical office. The hotline number is 1-800-762-0157. We also have the deaf crisis line, which is the text, the hand. And they can also, there's a warm line. We provide that as a resource as well. That's not listed up here, but there are warm lines for almost every state where people can call and talk to a peer. And then the National Suicide Prevention Lifeline, which is 988. So if, I believe the next slide we talked about. So psychiatric triage, that is our 24/7 facility. And we provide risk of harm assessments to clients on a walk-in basis. They can call ahead, and that is the phone number if anybody needs it. They're in Denton County and they want to refer someone or bring someone in. It's the 940-381-9965. We have a screening team that is available at all times for walk-in. We also have our community partners, which are police, schools, hospitals. They can provide referrals and send people to us, or family members and friends. If we have unaccompanied minors, we contact the Department of Family and Protective Services if we cannot get a hold of a legally authorized representative until Department of Family Public Services or the representative can present to the crisis center. And we have the police remain on site until they can get there. We also have our mobile crisis outreach team. So the mobile crisis outreach team provides face-to-face and telehealth assessments to individuals in crisis 24 hours a day. They can actually go out into the community. The team consists of 2 individuals, and they are mental health professionals or licensed professionals. We can respond anywhere in Denton County as long as the scene is secure and the client is medically stable. If we're unable to secure the location, we call local police department to come out and make sure the scene is safe before our clinicians go out there. And things that would make someone not medically stable would be if there's substance use involved. We have to have them medically cleared before we can screen them, or any sort of just medical complaints that they're having at the time. So before we send an MCOT team out to do a risk of harm assessment, the situation must meet the crisis definition, and that is having suicidal thoughts, homicidal thoughts, or deterioration within the last 2 weeks. Sometimes it can be a little bit longer. We just use our judgment and see how severe the situation is. Drug and alcohol levels must be acceptable for an accurate assessment to be completed and appropriate mental health treatment to be coordinated. So again, the client must be medically stable for the team to complete the risk of harm assessment. We have gone into schools before to do those assessments. I think now we're doing them more over the phone, but we can go into the schools. So police must go to the site first and stay for the entire assessment if the environment is unsecure or the location or client is combative. Secure locations include jail, Denton County MHMR office, hospitals, and that can be medical or psychiatric. We can assess individuals age 16 and up without a parent present. However, if inpatient treatment is recommended, a parent does have to be there to sign them in. If a client has insurance and is over 18 and wants to sign themselves into a hospital, they can do that, but they have to be able to sign themselves in. What are we assessing for? So when we do our assessments, we're assessing to determine if the individual is a risk of harm to themselves or others, if there are acute and chronic risk factors of suicide, if the individual's mental status for impaired or disturbed thought patterns, if the individual's social environment for distress or support, if there are any substance use issues, and to determine what is the least restrictive environment in which an individual can safely and effectively receive treatment. And then to facilitate inpatient treatment for the individual if the clinician determines that to be the least restrictive environment. So basically, we're trying to assess, can the client be safe for the next 24 hours or not? So if we can get them an ensure of safety, then they can stay at home. We would prefer to do that than send them inpatient because we are least restrictive. So what happens after an assessment? The team will determine the least restrictive environment for the client based on the information gathered. Due to the situation being a crisis, we can speak to other people that may have valuable information without consent of the client. So that could be parents, police, spouses, roommates. Outcomes will involve recommendation of outpatient treatment. So we have 4 different recommendations: outpatient treatment with ensure safety. We have voluntary inpatient. That's where the client is agreeable and they are able to sign themselves. And then we have involuntary inpatient treatment. That is when there is deterioration to the point that they can't keep themselves safe, or they are unwilling to go inpatient, but we feel the risk is great enough to where they cannot be safe out in the community. So what should you expect from our MCOT staff is a thorough risk of harm assessment based on least restrictive environment for the client. Response time to the scene is within 1 hour of receiving the call. So they have up to an hour to get there. And then those are some resources. So that is it. Thank you guys very much.
We have ended this presentation a few minutes early. So, Catherine, we have some questions that have come up in the chat. So I'll start by reading some of those, and then we'll open it up to other questions as well. So let me scroll back up here in the chat really quickly. Someone wanted to know what CASE stands for.
Oh gosh, y'all are going to put me in the spot. Let's see. Hold on one moment. I should know that. For CASE. Chronological assessment of suicide events. There you go.
Chronological assessment of suicide events. We had another question asking to review the safety plan slide again. So if you want to start pulling that up while you're doing that, I will scroll to our next question as well.
Safety planning. Can y'all see the safety planning slide?
Yes.
Okay.
So if you just want to maybe walk back through that, there's not a specific question that was attached to that, just potentially wanting to know a little bit more about safety planning.
Yeah. So when we do the safety planning with our clients, we first we set up a time of like when we're going to do our follow-up, and we start by assessing what the strengths of the client are. So a lot of times it might be that they're motivated for treatment, they have family support, they're med compliant. So we try to find any strengths that they present with and, highlight those for them. We also talk about areas for improvement. So we'll talk about, suicidal ideation, coping skills, relationships, or some of the other things, anxiety. So we kind of also highlight, like, these are the areas that we would like to work on with you if you're coming into services with us, or just areas that we feel you could improve in. So then we ask them, what are some warning signs that a crisis is developing? That can be things like, their mood will change. They become more irritable. They're more tearful, and just anything that they notice prior to having those thoughts of suicide or just the deterioration. We ask them what are their internal coping skills, things they can do on their own without having to ask someone else for help. And a lot of times people say, well, listening to music really helps, artwork. So those are just things that they can do without having to have someone else there to distract them. Then we like to get some names of people who can help provide distraction when they are having those thoughts. So it could be, family member, friend, teacher, and places they can go when they are feeling like they need a distraction. So some people might, they might go for a walk. That might help them to clear their head. And we often tell them sometimes just getting up and moving into a different room is enough to break that train of thought. So we often get pushback from people saying, well, there's not any place. Well, maybe going into like a bedroom or going into just a different area of the house. So we're trying to get those positive reinforcements of things that help them break those thought patterns. Who are people that they can contact when they need help? Family members, friends, teachers, anyone that they feel comfortable talking to about their situation. And then professionals or agencies they can contact in a crisis. We always list our center, we list police, and then the nearest hospitals in case they, feel that they need medical treatment as well. And how can they make their environment safe? We talk about access to means. So we'll say, if their thoughts are like, I want to cut myself or I want to hang myself, then we'll put in here removing anything that could be used as a ligature, removing any sharps, keeping medications locked up. And then what are their protective factors? What are their deterrents for completing suicide? That could be family, friends, pets. Maybe they got a new job, things like that. We're just trying to identify any protective factors. And then we also provide frequent phone or face-to-face follow-ups until their symptoms have decreased. And sometimes, clients will screen them and, 48 hours later, they're in crisis again. So then we start the process all over. Our goal is to get them stable enough to be in services and get out of that crisis mode.
Wonderful. Thank you, Catherine. That was a really in-depth overview. I appreciate that. We have a few more questions for you.
Okay, I hope I can answer.
With technology being in the forefront of the pandemic for teens feeling more comfortable reaching out via phone, is there any apps that you suggest that are like at the top? I know there are tons of apps in stores, including safety plan templates that you can use in real time during a crisis. Even parents can have them on their phone. So this person, I guess, is asking about any kind of like intervention apps or safety planning apps that you're aware of.
I am not specifically aware of any apps that are particular for that, because we typically, so my department, and I have a little less information on the follow-up part of it, is we're doing, I know that there are some text, like do you know what the text one is? Sorry, I have something else in my office.
So you can actually text 988 or 741 for crisis intervention. Both are textable.
But I'm not aware of like safety planning apps that we recommend at the moment. That's something I can look into though, but I don't know off the top of my head. Sorry.
Okay, we may circle back to that, do some research during the next segment and try to answer that question. Can you expand on the COMPASS program, the first episodic psychosis program?
So COMPASS is a program that was started a couple of years ago here at Denton County MHMR. They might have them in other places, but it is for individuals between the age of, 15 and 35 who are experiencing their first episodes of psychosis, either because of schizophrenia or maybe some other illnesses. And they get a case manager, they get counseling, and they do a lot of activities with them to keep them engaged in services. But it's for those first, and they stay in the program for a while. It's not just they go for the first episodes, but they stay enrolled in the program for a while. But the age frame is 15, so we said 15 to 35.
Okay, next question in our chat is, what is usually the time frame for MCOT to respond to a scene on average?
So it really depends. They have an hour, but we are doing things more virtually. COVID kind of changed everything for for everybody. So when it is when they have an hour to go out, but I'd say on average it takes about 30 minutes to arrive, because we also have to coordinate if we are going out to the site. We have to coordinate with police officers to have them come out and make sure the scene's secure. So it really kind of just depends, but it is within the hour.
Similar question, sorry, just off the top of my head. Do you know how long it takes the loss team to respond to get to a site?
So for the loss team, I am not sure that they have a specific time frame. I think, when we get the call, they try to make contact and then go out as soon as possible to be with the families. So it kind of just really depends for them.
Wonderful. Are there any other questions for Catherine? I think we've gone through the questions listed in the chat. Louise did point out that there's an app called Safety Net. She's put in the chat for us, so we could potentially look into that technological advancement, and then we'll do some research, see if we can find some other options for folks. Any other questions, please feel free to unmute yourself to ask. Okay. Catherine, thank you so much for your time and sharing your knowledge with us today. We are so grateful.
Oh, thank you so much.
Any other questions, thoughts, comments?
I agree. Any other questions, thoughts, or comments? Okay. Is it possible to get the slides? Yes, they have been sent to you in a packet. It should have gone to the email that you registered with. I would say sometimes they do go to your spam or your junk folder, so do check those folders. I know that's where it ended up in my inbox. So please look there. I am going to, we wanted some tangible takeaways for y'all today to leave with. So I'm going to share a resource that you'll find in that packet as well. So you will find this in your packet. We wanted a really an effective tool that would be applicable to your different practices. So this is something that hopefully you can use around the greater DFW area, and then hopefully even beyond that. So the first page of this tool is a levels of care kind of chart. So you could really use this with families to help explain different levels of care, sort of treating it like a step ladder, talking about at the bottom rung, you start in counseling, then work your way up to psychiatry, medication management, IOP, PHP, IP, RTC. So a really hands-on tool that helps break down what do all those letters mean and how can I effectively work with families to explain that. Whoops. So then the next page of that resource is outpatient levels of care at the PHP IOP level. So partial hospitalization and intensive outpatient level programming. I will say it took a lot of time and looking things up to create, but this is solely a resource. These things change often. Services change at places often, facilities change, so please do take it all with a grain of salt. To my knowledge, this is updated for the most part at this exact moment in time, but that could be different tomorrow. So what we also included for you all is hyperlinks to every single one of these. So when you scroll over a name, you could click on any of these and it would take you directly to the web page for that site as well. So hopefully this is an extremely user-friendly document. It tells you for that outpatient location, the name of the facility, Connections Wellness Group at these locations sees this ages, et cetera, et cetera. Here's the phone number and the type of program, whether that's PHP or IOP on the outpatient care sheet. So if we go to the next page, we have inpatient care options. So you'll notice a lot of these are centered around the DFW area, but they do expand outward just to provide a larger breadth of what is available. Again, with the hyperlinks to all of those options for you, age that they serve, and that includes children, adolescents, and adults as well. And then lastly, we included residential treatment centers. So you've got some RTCs around Texas as close as we could provide. You'll notice that that list is very short. And then some chemical dependency resources in our greater area as well. And for those on this call that are not in Texas, I'm sorry that this tool is not more applicable for y'all, but I certainly hope that it is a valuable takeaway for those that are attending today. So, are there any questions? I can't see all the things right now, so let me see. Let's see. Any questions about this resource? I'm sorry that it does not include insurances as well. It was a labor of love to get this compiled at this level. So, and again, things change. So do utilize this resource as much as you can, but you may want to look things up as you're going on. So you will find this in your resource packet. I am going to stop sharing my screen now. Are there any questions about the resource packet? Anything that y'all would like to know? Anything that would be beneficial in the future, please include that in your evaluation if there's a particular resource or something that would be a helpful takeaway. But since, of course, we're talking about these pieces and how to best serve our clients in different levels of care, we wanted to provide you all that tool today. Okay. All right. If there are no further questions about the tool, I am going to move on to introduce our next speaker. It is my joy and privilege to get to introduce these folks to y'all today. So without further ado, I have the privilege of introducing Catherine Richardson. Catherine Richardson is a licensed professional counselor in the state of Texas. In her clinical career that spans over a decade, Catherine has participated in and led teams in various capacities, including clinical, quality management, performance and compliance, risk management, and crisis intervention in diversity, equity, and inclusion. In her work as a therapist, she specializes in childhood trauma and play therapy, particularly enjoying her work with parents and traumatized children. Outside of her work, her passions include history, yoga, trying every cuisine known to man, and globetrotting with her husband and 2 sons. Catherine is the Director of Counseling at Connections Wellness Group. Thank you so much, Catherine, for joining us today.
Hello, everyone. I am so honored to be here with you all and honored to talk about this very important topic. I am thankful for y'all for all of the different ways that y'all work with teens and the support that you offer. So please know that the work you do is valuable. Now, one thing I'd love to know is just a litany of like, where all do you all work so that way I can kind of tailor my talk to, are most of y'all in schools, or most of y'all in nonprofit, or most of y'all in private practice? I would love to know. So if you'll put it in the chat, I'll try and look at it as I get going. All right, so I am going to talk about suicidality in teens. We are going to have a few learning objectives today. So I'm going to talk about the current research on suicidality. I'll just touch on that briefly. We'll talk about how to recognize the signs and symptoms of depression and risk factors for suicidality. So what do you as a professional need to be looking out for to make sure that the kiddos in your care are safe? We're going to talk about how to assess risk for harm and how to identify the appropriate level for treatment. We're going to describe 3 interventions for children and adolescents with suicidal ideation. And then we'll talk about one of my very, very favorite topics, trauma-informed strategies to build a culture of support. So I'm going to take a peek in the chat and look at where everybody is at. Okay, schools, private practice, agencies, hospitals, wow, clinical settings, house parenting group homes, probation, more hospitals, high schools. So we have a pretty wide array. So that's great. That means we're touching on a lot of different professions. Glad y'all are here. So let's dive into a quote that I heard back in high school. So I will tell y'all, this was back in the days of assemblies. I don't know if they even still do that at schools anymore, but when I was in high school, we had assemblies, and there was a gentleman who came to my school to speak. And I remember him saying this quote. I truly can't even remember what topic he was talking about or why he was there, but I remember him saying this quote: "The worst thing is to be alive and not know why." And this quote stuck out to me a lot. One, because I was already kind of thinking about being in a helping profession, but this really ignited my interest in the mental health field. And then another big aha for me in hearing this quote was the fact that there were people who felt this way, who were alive and they didn't know why. They felt hopeless and despondent. And I went to a magnet school. It was a very small school. We were all close and had everything going for us, so to speak. And so it was unimaginable at that time in my life that my peers, any of them, could have ever felt that way. It was unimaginable to me that any of them were suffering in silence. So hearing that quote really threw me off, because I thought to myself, surely no one I know is in this situation or thinking this way, because all of us had the world in front of us, what it seemed like. But as the years went on, as life passed, I did see mental illness emerge with a lot of my peers, and even with some of them succumbing to suicide. So when I talk about this topic, it is very personal to me, because this unfortunately has been the outcome for far too many young people who are suffering in sight. So let's talk a little bit about understanding adolescence. I have, like I said, a play therapy background. And so a big part of play therapy is understanding development and where a child is in that developmental sequence to understand how to best engage them. So this is by no means encompassing every single piece of development. I could do an entire presentation on development. We're just going to touch quickly on each of these different areas. So we have physical development. Everyone knows that around this age, there's the emergence of puberty, and that can cause a lot of smells, a lot of emotions, a lot of everything. And if you've ever been around teenagers, you know all of these things to be true. So with puberty, we have girls typically hitting their growth spurts in early adolescence, and then males hitting their growth spurts in later adolescence. If y'all have ever been to an 8th grade dance, you'll see a lot of little boys looking up to the girls as they're dancing, because they haven't quite hit that growth spurt yet. We also know that with these, with the emergence of puberty, with these growth spurts, everybody is on a different range. So just like with kids, there are some babies that walk at 10 months, and then there are some babies that walk at 17 months, and that's all within the range of normal. Same thing with puberty, but we do want to be aware of that, because that may be a source of embarrassment or shame for some kids who maybe aren't developing as quickly as the peers around them are. And then there's also, because of all this growth that's going on, a need for a lot of sleep due to the rapid growth that is going on for them. Really, teenagers at this age should be sleeping about 8 to 10 hours. Now, we do know that teens like to go to sleep late and sleep in. And as long as they're not missing school or work, that's okay, as long as they're getting in that amount of sleep. And as adults, sometimes they need a little bit of help from us, a few gentle nudges to make sure they get in the bed at a decent hour and they're getting enough sleep so that their bodies can rest and have energy to handle all the growth that's going on. So cognitively, we have a few things going on. We have the development of the prefrontal cortex, which came online years prior to adolescence, but is entering kind of its last stage of development. That prefrontal lobe, we'll talk about it a little bit more on the next slide. It controls everything from decision making to executive functioning to their ability to reason. And it's actually not done developing until their mid 20s. So around 23 for females, around 25 for males. Fun fact, that is actually why it's quite expensive to rent a car if you're under the age of 25, because insurance companies, rental car companies know you're probably a little bit more likely to make some not so good decisions before then. And then there's an increased capacity for abstract thinking. So this is why you get a lot of questions. Now, for those of y'all that are teachers, these can become quite annoying sometimes, and sometimes seem as come off as defiant, and sometimes they are, and sometimes it truly is them just gaining a wider scope of how the world works. Prior to this, their thinking is very concrete, very black and white, but now they're starting to see the gray. Kids at this age also love to correct adults because they think they now have it figured out because of their brains growing at the rapid pace that they are. And then the last piece in cognitive development that we'll talk about is egocentrism. Now, this is the idea that the world is about me. I'm sure it's one of our favorite qualities in a lot of teenagers. And some of it is just natural development. Kids have to be a little bit more self-centered. It's the way that they let us know that they have needs that need to be met because they're not able to meet a lot of their needs. With adolescents, this plays out particularly with a concept called the invisible audience. So this is when they feel like all eyes are on them. If you are working with teenagers at all, which I know a lot of y'all are, then you have experienced this where maybe they have a pimple or maybe they slipped in the hallway and they're like, everyone's looking at me. It's horrible. And you're like, actually, no one's looking at you because there's hundreds of kids going up and down this hallway. No one is thinking about you. Chill out. But for them, it feels like the end of the world because it really does feel like everyone is thinking about them all day, every day. So sometimes for adults, they need us to give them a little bit of that reality testing and remind them, hey, everybody's not. You are okay. All right, let's talk about socio-emotional development. So with the roles of friends and family, those do change quite a bit in adolescence. Kids, when they're babies and in that early childhood stage, they start off with their caregivers being primary. That is who they like. I remember my second child did not leave my hip for at least 2 years because he loved his mama and he wanted to be around me all the time. And then as they grow up, their social circle expands to classmates, to people in the community, extended family, grandparents. And I want y'all to know eventually he did let someone else hold him. And I was very thankful for that. But kids start to recognize that the world is much bigger than their parents and close caregivers. As adolescents, they start to look out to friends and sometimes even teachers or other adults in their lives as their primary source of influence. Now, that does not mean that family members and the safe adults in their life are no longer important. Their role just changes. So with teens, it's helpful to be more of an advisor and less of an advice giver or less of a coach because they don't like to be told what to do because they think they know it. And so playing that role of an advisor really does help them to still trust you, still confide in you, but in a way where maybe we're not giving as many directives as we are when they're younger. I love, love, love interpersonal neurobiology and just talking about the brain. I don't know how many of y'all are familiar with the term, but just to keep it very, very basic, it is the study of how our experiences, our relationships, our world, our external world can affect the actual anatomy of our brains. And so this is really important when we think about dealing with teens and their mental health, because depending on if they've experienced trauma, depending on if there were interruptions with development, this can affect the way that they regulate quite a bit. So one of the things that I use with kids, with parents, with everybody is the hand model of the brain. And you can literally look it up on YouTube. It was created by Dr. Dan Siegel, who wrote a book that I'll quote often in this presentation, The Whole Brain Child. And it talks about the three different parts of the brain. So down here, and it's actually right behind our necks, you have your brain stem. That is your survival brain. So that's controlling all of your instincts, your ability to digest food, your ability to sleep. That comes online in utero. And then just above that, we have the limbic system. Within that, that controls all of our emotions. It actually also controls us looking out for danger. And then just above that, we have the prefrontal cortex that's right behind your forehead. Now, that's the part that we talked about before that's coming online or developing in adolescence. And that controls a great deal of our ability to make logical decisions. So our brains are constantly learning what we need and what we don't need. So it's taking in information that it knows will be helpful to us. And then it's throwing away stuff that we don't need. So if you have a teen who's maybe in trigonometry, you have them. I'm so sorry, was there a question?
No, just a person that needed to be muted. Apologies.
Okay. No problem. I want to make sure I have two small kids. I'm used to being interrupted all the time. So if anybody has a question, feel free to jump in. So our brains are constantly taking in information that we need and throwing away what we don't need. So if you have someone who's taking a particular class like trig, they're taking in a lot of math, they're able to retain that information because their brain is saying, oh, we're going to use this, let's keep it, versus phone numbers. Almost none of us know phone numbers anymore. We did 10, 15 years ago, but now that we don't need it anymore, you probably couldn't tell me 3 people's phone numbers off of the top of your head, because our brains have learned we don't need that information. We're going to toss it out. This is a way for our brains to conserve energy so that we're able to perform certain functions without thinking that much. So think about things like brushing your teeth, driving to work. You probably don't have to think very hard to do those tasks, and that's your body conserving energy so that when you do have to use a lot of energy to do a new task, you will have that bucket available to you. So this idea of our brains taking in new information and getting rid of what we don't need is called neuroplasticity. So that is the ability for us to make new brain paths and internalize norms. Another concept that's really important as we talk about this topic and its relation to interpersonal neurobiology is nerves that fire together, wire together. Now, this is important as we think about working with teens because they can associate two things that maybe we see do not go together at all. So I'll give you an example. If, when I was growing up, this is totally untrue, I'm just making up something for the case of an example, but if when I was growing up, every time me and my family went to McDonald's, my parents fought. And then at a McDonald's, they told me that they were getting a divorce. Obviously, I know McDonald's has nothing to do with my parents' marriage at all, but I may associate McDonald's with sadness, anger, frustration, my family breaking up, because all of those memories happen at a McDonald's. And so why this is important, 2 reasons. Again, we may see some things as completely neutral, like not triggering at all, but a teenager may have had a certain memory or an experience or a reaction that occurred that caused them to link the two of them. So kind of being mindful of that as you work with them. And then also thinking about how we talk about mental health is very important, even if we're not trying to say negative things about people who seek help, just those subtle comments like, oh man, can you believe that that person struggles with anxiety? You would never know. She doesn't seem like it. Well, that can give off the impression that there's a certain look to anxiety or a look to depression, or only those people struggle with that. So just being mindful of the language that we use as we talk about that so that they don't relate mental health with weakness or being crazy, or maybe you can't seem to pull yourself up if you struggle with that. We want them to be able to come to us when they are struggling and know that we won't judge them. Let's talk very, very briefly, because I know y'all had some other talks about this, just about the current research on suicidality in teens. So on here, I have a few statistics for you, a few percentages. 13% of high school girls had attempted suicide, while 30% had seriously considered it. Now, I know as you look at these or see these, you can maybe think, okay, 13, 30, that's not that bad. But that's a third of teenage girls that are ruminating over ending their lives. That is quite significant. And then the next piece is 20% of LGBTQ plus teens had attempted suicide, while 45% had seriously considered it. So we see that there is a heightened risk factor there for certain teenagers that we want to be aware of. Now, 57% of girls and 29% of boys reported for persistent feelings of sadness or hopelessness. Now, I didn't put this number on here, but the number for actual completion of suicide is actually flipped. So you have more boys typically that will follow through on suicide versus females. And that there's different views on why that is. One of them is that girls tend to be a little bit more right brain heavy, tend to be a lot more emotional, and we will ruminate over our feelings a little bit more than guys who kind of just have an impulsive thought and will act on it. Next piece is 76%, of students surveyed said that they would be more likely to turn to friends for emotional support, compared with 64% who would reach out to their family. One thing I want y'all to notice on here is this goes along with what we talked about earlier. Families are still important. 64%, over half of teens said that they would reach out to their family members if they needed emotional support. So friends are important, and we want to surround them as much as we can with healthy friends, but family also is. So I really hone in on that with parents of teenagers, to let them know you do still have a place in your child's life, and to exercise that influence that they have. And then the last one is the odds of dying by suicide are twice as high in rural America compared to urban areas, due to ease of access when it comes to weapons. And we'll talk a little bit about the link between access, means, plan, and intent when it comes to assessing risk. So with suicide rates, we did see a decline prior to the pandemic, and then a sharp rise soon after. And that sharp rise, as you can see from the second set of numbers that I put on there, disproportionately affected a lot of marginalized groups, such as teens who identify as LGBTQIA+, American Indian and Alaskan Natives, and particularly adolescent Black girls. So when you look at these numbers, I know we're not doing kind of a back and forth, but I like each of you to think about, and if you'd like to just maybe place in the chat, what is the story that these numbers tell you? Obviously, behind these numbers are actual people who have lost their lives or who have either considered it. So we want to look at these numbers as people and stories. And when you look at the trends there, is there a particular story that these numbers are telling you? So if you'd like, feel free to put any thoughts you have in the chat. All right, let's talk about spotting the signs. So you're working with kiddos, you are, whether that's in probation, whether that's in school, whether that's in an agency, and you're wanting to know, okay, what do I look out for when spotting this? So first is previous mental health conditions such as anxiety, depression, or trauma. Adolescents who have previously been in treatment may feel helpless, as if nothing's going to work to actually help them with their problems. They may feel like, I've kind of been down this road before. I already know how this ends, and it doesn't end well for me. So I am just going to give up. The next piece is looking at a family history of suicide, violence, or substance abuse. Being in a challenging environment already comes with its own issues, especially if that child is being put in the role of an adult long before they're ready to actually step into a role as an adult. So they already may feel that added pressure. They already may feel that added stress of being in a difficult environment. And then you put on top of that their own emotions that they're trying to navigate. And then they may have parents that are just not in a position to support them in the way that they need to because they're battling their own addictions or they're dealing with domestic violence. And as much as they would like to be there for their child, they just do not have the capacity to help them cope. The third piece is that stressful life event that we talked about. Because of that invisible audience, sometimes that can bring on a lot of stress for things that we as adults may know, like, okay, broke up with your girlfriend for the 10th time, like, you're going to be okay. Well, they don't feel that because in their minds, they feel like this is the end of the world for me. So stressful events such as a breakup, having trouble at school, like maybe they didn't do so well on a test, if it's a kiddo that puts a lot of their worth in how they perform, or conflicts with friends, and especially if a child has just a few friends or they're particularly isolated, if they lose like the one or two friends that they have, that can be a huge blow to them. So we want to help them in this way by entering into their world, by trying to understand what is it and why is this affecting them in the way that it is. We don't want to minimize. We don't want to tell them it'll be okay and give them false hope because they may not get back with their girlfriend or boyfriend. And we don't want to make them feel like those things aren't important. We do want to emphasize that there will be other happy moments in their life outside of maybe what they experience with that individual or in that situation. And then little to no access to mental health resources. I'm sure so many of y'all who work out in the community see this, but there are lots of kids who are either underinsured or have no insurance at all, or maybe they live in areas where there is just no resources at all. There may not be a therapist or a psychiatrist or a treatment center nearby for them to get the help that they need. So this can be a huge risk factor because when they need something or somebody, there is nowhere to go. And that presents its own challenges. It can be easy, and I didn't put this one on here, but I always like to touch on this. It can be very easy to discount certain cries for help, especially if you've had a teen who's threatened suicide many, many times. It can be easy to just kind of brush off the gestures, treat it as a cry for attention, and deny them treatment or deny them help. But you really do want to treat each of these as if they're the real thing, because this might be the time that they actually go through with it. So we want to make sure that as we're working with these teenagers, that we're looking at, are they really, are they giving us that cry for help, and how are we responding as if it's the first time that they've done it? Take a quick drink of water. What to look for. So let's look at some of these example statements. These are, again, by no means all encompassing, nor the warning signs, but just some things to look out for that may not be explicit, I want to harm myself, but maybe some of those passive statements that you want to, when you hear them, you want your antennas to go up just a little bit. I wish I could go to sleep and not wake up. I just want the pain to end. No one can help me. There's nothing left for me. So being aware when they're saying these things, what the deeper meaning may be, because most kids are not going to come out and say, I want to kill myself. They're going to give you these crumbs, these clues that you want to be aware of, and then they are wanting you to take action. They may not know that's what they want, but that is what they're wanting because they're saying that to you. So almost like a cry for help, an indirect one, because they need help, even if they're not saying it explicitly, they need help. So you want to look for any statements that have hopelessness in them or just a apathy about the future. And then warning signs that you're looking for is just sudden changes in their behavior that are long-standing. So all of us have a bad day, all of us have a bad week, but what you're looking for is things that don't go away. So one of the ones I put up here was a drop in one or more letter grades within a grading period. So if you have a 9-week grading period, they're normally an A student. They go down to a B. Okay, little red flag. Maybe it was a hard class, but then if they do it again and again and again, like every 9 weeks for the next 3 weeks, for the next 3 grading periods, that's something that you want to look into. And maybe they're dropping a whole nother letter grade. So 2 letter grades in a grading period. That's a pink flag that you want to be aware of. Increased isolation from their typical support network. Now, there's a range here. You do have some kids who are introverts and who just rather not really be around people a lot, and that is a-okay. Whereas you have kids on the other side who are extroverts and who want to be around people all the time. So knowing this kid, looking at what has changed for them. So if you have a kid who's more gregarious, who's around others a lot normally, and then they all of a sudden are just sitting at home by themselves on the weekends, or they're eating lunch by themselves, and this doesn't seem normal for them, you want to have that little antenna raised again, because that may be a sign that something deeper is going on. If they're posting questionable material on social media, so again, looking for things outside of their norm. So maybe they're posting more things about suicide, or some of the language is similar to some of the statements that I said, or if they're posting things that just seem odd and maybe start to fall into the avenue of risky behaviors. Now, risky behaviors could be sexual acts with strangers, truancy, so missing school, and then substance abuse. So any of those behaviors where they just kind of stop caring and they go into when we're assessing risk, we want to think of it as if, or not as if, it is a spectrum. So we want to look at the spectrum. So anytime we're thinking about those warning signs, anytime we are thinking about those statements that we're saying, we want to have this spectrum in mind. Now, this doesn't mean that if it's at decrease in functioning that you don't worry about it. That just means we change where we're referring them to. So risk could be anything from a decrease in functioning. Now, again, that could be occupational, like they stop coming to work. That could be they stop performing in school and have that 2-grade letter drop. They stop taking care of themselves, so they don't want to brush their teeth. They don't want to take showers. Their appearance looks very slovenly. Again, these are teenagers, so within the range of that child's norm. And then we have self-harm. That could be anything from actual cutting to banging their heads to binge eating. Some people even consider that self-harm, like we're even eating to the point where someone vomits. So anytime where they're using harm to themselves to like release an emotion for their own emotional coping. Now, it's not coping in a positive way, it's maladaptive coping. And then passive suicidal ideation. So that's when they're saying a lot of the statements that I just talked about, where I just don't have anything to live for. What's the point? I just wish I could go to sleep and not wake up. So they don't quite have like, this is the plan. I want to do this on this day at this time in this way. But they're toying around with what it would be like to not be on this earth anymore. So we want to still pay attention to that because, again, it's on the spectrum, but maybe tailor what our treatment intervention is to that. And then active suicidal ideation. This is what most of us who are not doing therapy or assessments day in and day out think of when we think of being suicidal or just risk in general. This is someone who hits all four of the categories that I'm about to talk about. So plan. Do they actually have a plan to hurt themselves, or is it just a thought, like with passive suicidal ideation, where I just want to go to sleep and I don't want to wake up, but they haven't said, I want to do this on this day in this way? Do they have the means to actually carry out this plan? It's a very important one, because if someone's plan is to jump off of the Golden Gate Bridge in San Francisco, but they live here in Texas, that's not really a accessible plan for them. So that's a much different plan than someone who says, I go over a bridge every day when I drive home from school. I'm going to jump off of that bridge. Much more imminent. Definitely want to move very quickly on that because they can act on that at any point. Third piece is intent. Do they actually want to carry out this plan that they've said, or do they express wanting to live? So I've had many teens that I've worked with who will say, I have a plan, I have the means to do it, but I want to live. Like, I don't want to do it. And it's almost like it's an intrusive thought to them. And then the fourth piece is just access to any kind of weapon. So that could be guns, knives, scissors, rope, anything that they could harm themselves with. So when we're assessing, we're thinking about those four categories. And for sure, if someone meets all four, we're probably going to go to the most acute level of care, which is an emergency room. We'll talk about that in a minute. But if someone maybe has one, like they have a plan, but they don't have the means to carry out the plan, and they don't have intent, and they don't have access, then maybe we can look at an outpatient PHP setting. So how can you help? That's why most of y'all are here, is y'all want to help these kids have futures and have hope. So help could look like you stepping in to provide that assistance or that treatment if you are a clinically licensed provider, or you work for a hospital or something like that. Or it could be showing them where they can get help. So before we talk about where specifically we want to send kiddos, I want to talk about a couple of interventions that you can use with them. One of them is motivational interviewing. Now, this is something that you don't even have to be licensed to use it, but we do use it a lot in therapy. We use it a lot in assessments because we are trying to move that person toward change. So motivational interviewing at its core is used to increase the individual's ability and capacity to toward the change. We're not making the decision for them. We're not forcing them into anything. Although as adults with minors, we do have to be maybe a little bit more assertive in what we're sharing than we would with another adult who's able to consent for themselves when it comes to treatment. So during motivational interviewing, we're doing a couple of things. We are asking solution-focused questions. So we're asking questions like, what would it be like if you weren't depressed every day, all day? What would it be like to feel happy about going to school, or to at least feel content about it. So you're asking them questions that have to do with what we want to move them toward. We're focusing on the goal and not the roadblock, because there's always going to be a million roadblocks. So we're focusing on what does it look like for us to hop on over those roadblocks and get them the help that they need. This helps to build autonomy for them. It helps to encourage agency, because again, we're not making the decision for them. They are deciding what is best for them with some guidance and help from us. And it also helps to engage their cognitive brain. So when you're trying to regulate, you are wanting the left side of your brain, which is much more logical, much more about text and specifics. And then the right side of your brain, which is more emotional and contextual, we want those to communicate with one another. Many times when we're highly emotional, which it's not wrong to be emotional, but if we're emotional, remember our hand model, the brain, we can't access that thinking brain. So we're wanting to move them into that thinking brain so that they can make a logical, healthy, wise decision on how to help themselves and how to ask for help from others. And we're using skills such as reflective listening and summarizing that are not accusatory, that are not saying, well, if you had gotten a hold of this earlier, this is not the time to prove that you're right. This is the time to show them you're supportive, to show them that you understand, and to show them that you are in it to help them get safe. Some therapeutic interventions, if you are a clinician or if you're referring them to therapy, you can look for individuals who specialize in these. Cognitive behavioral therapy studies how thoughts, feelings, and behaviors all link together in a triad. And it's very, very popular. It's an evidence-based treatment. It has tons of research behind it. And it's very effective with individuals who have depression only, amongst a lot of other things. But for our context, it's most helpful for those who only have depression. And then we have dialectical behavioral therapy, which still has that triad component, but they also add in a lot of regulation pieces. And it's very effective for individuals who either have personality disorders or bipolar disorder, which means that they have those emotional highs and lows. Group therapy is incredibly effective for teens, because it relieves that pressure that they can sometimes feel with just having to talk to an adult by themselves for an entire hour. And it also gives them peers and can normalize their experience to, oh gosh, I'm not the only one who feels this way. And then the last one is eye movement desensitization reprocessing, otherwise known as EMDR. It's the new hot thing these days. And I can say, as someone who administers it, it is highly effective. It uses somatic bilateral stimulation. So again, accessing or stimulating both sides of your brain to help reduce the intensity of a lot of those emotional symptoms. Safety planning, something you can do even if you're not a clinician. And this can be as formal as like you have a template in your office and y'all write these things down. This can be as informal as a conversation. It just depends on where they are in that risk spectrum. So if you have someone who's more on the acute side, so maybe they're in passive or active suicidality, my recommendation is that you do write down each of these things and have them sign it, have parents sign it whilst you're getting them to safety if you are not a clinician yourself. So part of safety planning is always going to be securing weapons. When I'm doing this with teenagers, I'm asking, do they have access to scissors, knives, guns, rope, even something as simple as like a threading needle for your eyebrows. So anything that's sharp that they could potentially harm themselves with, at least temporarily when they're in this heightened state, like we need to secure those and make sure that they don't have access. Who's their support network? Are there friends and family and safe adults that they can reach out to? What are some coping skills they can use? This looks different for every single person. For some people, it's drawing. For some people, it's walking. For some people, it's cooking a meal. So we want to be aware of at least 3 coping skills that they can access if they begin to feel unsafe. And then what are those emergency numbers? So providing them with information to the National Suicide Hotline, to your local county's MHMR or mental health authority, and probably the number for the nearest emergency resources. So I listed these in no particular order, but I'm gonna, as I talk about them, kind of group it like a spectrum with risk. So on the less severe end, we have counselors, therapists, psychiatrists, and psychologists. Those are all of our kind of private practice level, your baseline of, I'm just dealing with run-of-the-mill depression, but I'm not suicidal. I'm not thinking about hurting anybody else. I just need some help working through my emotions. Particularly psychologists work with folks who need additional testing. So usually some psychologists do counseling as well, but some only do testing. So you'll only see them for the purposes of that. And then psychiatrists, while some do counseling, most of them do medication management. So that would be kind of like a half step up from therapy or seeing a psychologist of I am not getting what I need from therapy. My body, my brain needs some help making the hormones that it needs so that I can have joy and make healthy choices for myself. And then the next step up would be our outpatient programs. So at Connections, we have partial hospitalization and intensive outpatient programs. What those are is in some ways will mimic what it's like at an inpatient hospital, but you get to go home and practice some of those skills that you're learning. So when you're at the inpatient hospital, you're there, it's kind of like the equivalent of an emergency room. You're there to get stabilized so that you can go back into your life. Usually most of those people are stepping down into a PHP or IOP program where they're going to treatment. For PHP, usually it's 5 days a week. For IOP, it could be 5 days a week, but just a shorter day or only 3 days a week. Just depends. And with PHP, you have a medication management piece. With IOP, depending on the program, you could or could not have one. And then you have inpatient hospitals and the emergency. Those are going to be your most acute places where you see folks who are on that very end of the spectrum when it comes to risk. Typically, emergency rooms are kind of the entry point, and then they will refer or transfer to an inpatient hospital. Most kiddos will be there for about 3 to 5 days. They'll stabilize them and then discharge them and step them down to an outpatient program. In some very few cases, especially depending on insurance, they'll step them down to a psychiatrist and a counselor. So we'll end off our time talking about some trauma-informed strategies. Since this is my specialty, I could talk about it all day long, but I know that we are almost out of time, so I'm going to try and be very succinct. But when we think about kids from hard places, we want to use a lot of the techniques that we just talked about, but tweak it just a little bit, knowing that their development, their experiences, their relationships, or sometimes lack thereof, may be contributing to their brain working differently or to them just seeing the world differently. So when we think of how to engage them, we always want to start with connection. Always, always, always. We as human beings are hardwired for it. So if you do nothing, just work on establishing that relationship of trust with them. Just like we talked about, that right side of the brain that's much more emotional and the left side that's more logical. We want to, when they are heightened, connect with their right side of the brain and correct with their left side. So connect with the right, correct with the left. And this is a concept that Dr. Dan Single and Dr. Dan Siegel and Dr. Tina Bryson talk about in their book, The Whole Brain Child. And it's the idea that when we're upset, again, we are not in our thinking brain, we're probably in our feelings brain or even in our survival brain. So we need someone to help regulate us and get us back up to that thinking brain. So we want to always start with connecting with, getting down on their level, talking calmly, using active listening, helping them to regulate so that they can access the thinking side of their brain and actually hear what you're saying. So many times we can talk at kids and we're expecting them to take in all that we're saying, but really they're not regulated, so they're not hearing much of anything that we're saying. Choice giving is one of the topics that is so important when working with children who have experienced trauma. They've had a lot of things happen to them. They have had a lot of people making decisions for them. And the worst thing we can do is be someone who's added to that list. It's also important to remember that for children from hard places, depression can manifest as irritability or defiance. And so we want to be very aware of how we're coming across, or maybe even how we're perceiving their behaviors. It's typically not defiance. Sometimes it is, but typically when you see defiance from these kids, it's actually a way for them to meet their needs. They're feeling in the moment like they're out of options, they're dysregulated, but because they haven't had safe adults in their life, they don't really know an alternative. So it's up to us to help give them some healthy choices that they can agree to. Now, we want to make sure that these are options that we are okay with. So we're not going to say, if we have a suicidal teen who has a history of trauma, you can either go home or you can go to the emergency room. No, that's not an option. We can say you can either go to the emergency room with your parent, or you can choose for me to follow you there and I'll meet you guys there if you need another person of support. And this giving of choices, even if it's choices that they may not love, it helps to build their autonomy so that they can learn how to make those healthy decisions on their own. And it also builds their capacity to problem solve for themselves. Excuse me. So I'm going to end off with my references. Are there any questions for me before I end off? I'll take a peek at the chat just to see if there's anything that came up.
Yes, you took the words right out of my mouth, Catherine. Are there any questions for Catherine today following her presentation? Feel free to put it in the chat or unmute yourself and ask.
I think it would be wise to include on the preventions chemicals and cleaning supplies, which kids, when they are emotionally unstable, that's a way to perhaps maybe harming themselves with the cleaning supplies. And they are readily available in the kitchen. Another thing to keep in consideration is if you're living in a building, okay, you need to secure the windows because that's an easy way out to do whatever. So those two things, I think that it needs to be kept in mind too.
Joseph, that's such good insight. Thank you for that. You're very right about cleaning supplies and about if somebody's in a building and they're on something that's other than the first floor. That's something that we would want to be mindful of during that safety planning process. Thank you for that.
You're welcome.
Any other questions for Catherine? A lot of thank yous in the chat, Catherine.
Yes, I enjoyed doing it. Thank y'all for your attention. And I hope that y'all enjoy the rest of the presentation.
Wonderful. Thank you so much, Catherine, for your time and for sharing with us. I have the privilege and honor of introducing the next speaker who I've known for many, many, many years. So without further ado, I would like to introduce Tasha Moore. Tasha Moore joined Communities in Schools North Texas in 2012 as a middle school site coordinator, and over the years has also served as a program director and the chief operations officer. Tasha currently serves as the Chief Executive Officer and is responsible for leading and overseeing the implementation of CISNT's organizational vision and strategic goals that support the mission to surround students with a community of support and empower them to stay in school and achieve in life. Tasha received her master's in social work from Baylor University and her master's in divinity from George W. Truett Theological Seminary. Every child deserves the opportunity to learn and grow in a nurturing environment that empowers them to realize and achieve their full potential in life. It's this belief that has motivated Tasha to pursue a lifelong career of collaborative work with schools and the community to create limitless spaces where all children can recognize their strength and achieve their dreams. Thank you so much for being here today, Tasha, and the floor is yours.
Thank you, Lindsay. Okay, let me make sure I can do technology and share my screen. Well, good afternoon. Thank you so much for letting me just share a little bit. I'll preface this with my experiences in schools with a short stint in youth ministry, but a lot of these strategies around creating culture can be used across any setting, whether it's a clinic, a work environment, a school, just a regular office or job setting. So just know I might use school examples, but this will work across anywhere. So I thought I might start with talking a little bit about some of the common myths we might hear or have heard as it relates to suicide and self-harming types of behaviors, because I think it's really important to talk about what those myths are and unspoken assumptions or rules that we have, because it influences the environment that we're creating for people and the environment that we're in. So the first myth is talking to teens about suicide makes them more likely to want to kill themselves. And the reality is that talking about suicide provides a space and an opportunity for them to share what they're thinking and what they're feeling. It creates the environment that lets them know you can feel comfortable and be vulnerable, and these are safe spaces and safe people. It also gives the space for the people that they're talking to say, hey, I understand. We've all been there. We've all had rough days. We've all had rough times. So let's find you some support. Let's find you some resources. And that environment also provides the individual the opportunity to seek help and to know that they don't have to stay where they're at. So not talking about it is probably more harmful than providing that space to talk about it. Myth 2, talking about a completed suicide will only lead to more attempts. And that's a hard one, but part of it is recognizing that we've lost a loved one, a friend, a classmate, a coworker, and that's devastating. And so we need a space and we need opportunities to talk through that hurt and that loss and that pain. And for some individuals, that also might be talking about the guilt or the what did I miss, or how could I, or what should I have? And that also helps people know that the space and the environment that they're in is safe and caring. It also provides that opportunity when you are talking about those hard situations, a chance to check in on individuals who might also be having similar thoughts, and you can just take their own temperature. How are you doing? How are you feeling? So it's never a bad thing to provide that space to talk through what people are experiencing. Myth 3, and I heard a couple people touch on this earlier, is, well, suicide only affects individuals with a mental health condition. And the reality, too, is suicide does not discriminate. We all face stressors and crises that impact our daily life. For some of us, it's short. I had a rough day today. Today's been a really hard week. But for others, it might compound day after day. Sometimes the stressors around race, ethnicity, sexual orientation, economic status, like all of these things play on us day in and day out. And so you don't have to have a diagnosis of a mental health condition to be susceptible or need support and help through suicide or self-harming behaviors. And then a fourth myth is that really it's just in someone's head. They're just overreacting. And to be honest, again, we all face problems. We all face struggles, but we have to keep in mind that how I might perceive a situation or someone else might perceive a situation, our level of distress, our level of feeling alone is going to vary. And so letting somebody know that it's not in your head. I understand your feelings. I see how you got there. How can I help? How can I support? It's also a very important thing. So again, talking about some of the myths and just recognizing what we might have assumed or what we might have heard, and even for other individuals, what they might hear in that stigma behind mental health, letting them know that the spaces that they're in are spaces that are supportive for them, are really important in creating that culture. The other thing that's really important to talk about, and I heard this get touched on as well, is trauma. And what is trauma? Because the trauma that we experience throughout our daily lives also can play into our own mental health. So I'll do this briefly because there's so much to unpack with trauma, but trauma is the exposure or an incident to a series of events that can cause something to be emotionally disturbing, upsetting, life-threatening. It can cause us to have an adverse reaction to how we live our life or how we function. It can impact our physical, our social, our emotional, our spiritual well-being. And so that, again, is individual. What might be traumatic for me might not be traumatic for somebody else or vice versa. But it's all about how we live and perceive and work in our daily life. Some examples of traumatic events could be anything from major things like war and violence, terrorism, natural disaster, hurricanes, tornadoes. It could also be things that happen in our daily life on an ongoing basis. Experiences in living in high poverty, high violence, or crime areas, experiencing physical or sexual abuse. Trauma can also be the sudden loss of a loved one or watching a loved one struggle through a substance use disorder, a mental health condition. Trauma can be a social justice or a systemic issue mentioned earlier, so just about racism, homophobia, transphobia, poverty, the weight that can leave on an individual who is experiencing oppression or discrimination can have a long-term impact, not only on them as an individual, but on the communities that they're a part of. And that has a generational long-term impact. So again, thinking about the myths that we might have heard, thinking about what trauma is and how trauma can come across in very different ways and have very different experiences for individuals, are also things that we need to keep in mind when we're thinking about how to create a culture and an environment that is both inclusive and safe for everybody, but is also an environment that's going to help to remove those barriers so that people can thrive and really take on this whole life that they have before them. So when I think about trauma, I always think about what does this look like through the eyes of the kids that we serve in our schools. And so if you think for a second and put yourself back in like 3rd grade or 6th grade, some of these traumatic events, what does that look like for a kid? An adult hurt me. Now I'm going to flinch every time an adult comes towards me and they look angry. I get yelled at a lot at home. So when my teacher raises her voice to get the class attention, I back away. I kind of recoil in my chair. There's a lot of scary sounds in my neighborhood. I hear a lot of different things that happen at night. So if it was really noisy last night, I might not show up at the bus stop if I'm the only kid at my bus stop. I might skip school that day. I hear a lot of, I don't have lights on in my house sometimes, and sometimes it is, and sometimes it isn't. And so I can't really do my homework, and I don't really care about my homework because I can't see when I'm at home, or I don't have food at home. And so that's why when I rush out of the classroom, I run down the hall to get in the line. I'm hungry. I want to get in line, but I don't have that resource at home. And sometimes I'm just bullied, because of how I look, because of how I dress. There's lots of things that kids experience that are traumatic for them, that are shaping their responses to things, that are shaping their behaviors. One of the things that has just stuck with me for a few years now, if you remember back when we had the big ice storm where everything, electricity was out, it was freezing cold for a week. There was a lot that happened to families and to individuals in that time. You fast forward about a year later, we had another ice storm. And I remember sitting with one of our staff members who works on an elementary campus. They were telling me they had this kid who they got called on the walkie because they were just having an outburst in class. And they went down and they picked up the kid and they walked back to their office. And they said, what's going on? Why are you so upset? And for a while, it took some time for the student to calm down. But finally, the student shared, I'm afraid. I saw on the news this morning and I heard on the radio coming in that there's this big ice storm coming again. And I don't want to go through an ice storm again. And our staff member said, well, but don't take this the wrong way, but wouldn't you be excited for a snow day? Like, wouldn't you be excited to have a day where you miss school? And the kid said, no, snow days are not good. Snow days mean no lights. They mean I'm freezing cold. They mean there's no food to cook. And what that meant was, for some of us, a snow day is exciting. It means sledding. It means snowman building. It means no school. But for this student, that experience of the really long week of ice and snow was scary and traumatic. And so on their way to school, when they heard something like that was going to happen again, they went into this survival mode. They went into this fear mode. But we didn't recognize, as a school, we couldn't figure out what was going on. So it's important to remember that how we perceive our experiences and our traumas are very different. That story has always stuck with me these last few years when I think about providing trauma-informed care. The other thing to think about and talk about with trauma is secondary traumatic stress. And so that means, what is it like as a caregiver experiencing and hearing the stress? So when you're creating a culture of support, it's not just about your students or your clients or your congregants. It's also about the people who are serving alongside with you. Secondary traumatic stress, it's defined as the emotional stress result for the individual that's hearing, that's seeing, that experiencing other people's trauma through their service. It's really common in professions that are helping professions. So teachers, pastors, nurses, social workers, counselors. You're in the field that you're in because you want to support people and be there and help them through those hard times that they might experience. But it also means that you're reliving those experiences with them. And that has an impact on your own mental health. So what does that look like? Depending on the individual, they might experience increased anxiety. They might find that they're trying to do their everyday work, but those thoughts, those experiences, those photographs keep coming back into the forefront of your mind. Just might be exhausted. A normal day might not have left you quite fatigued, and now every day you just come home exhausted, tired, achy. Those could be part of that secondary stress and trauma. But when we think about creating a culture, it's really important to think about everybody's involvement and everybody's experiences related to that. Okay, so now if we were to really think about how to be trauma informed, like I said, it means to be mindful of the behaviors that are being displayed, that those behaviors typically are related to a survival or a trauma response. They've been learned, they've been taught. But what is so great is our brains are just so adaptive, and that we can help to teach new strategies, create new environments and new cultures that build new connections in our brains, so that we can, instead of just trying to survive, we can start thriving. To create that culture, though, that works on trauma-informed practices and trauma-informed care, we have to be honest with ourselves and with our organizations and take a deep dive look into who we are. Do we realize how trauma impacts our students, our staff, our parishioners? Are we equipped in how to recognize those signs and symptoms? Are we equipped with our responses, our policies, our practices? Are we making sure that we're not re-traumatizing, even if it's our best of intentions? How is what we are trying to put out there as supportive being received? And so always this constant evaluation. To truly be a culture and a system that's trauma informed, it has to go across the whole organization. And it's not just about providing trauma specific services or programs or interventions, but it's a top-down, bottom-up approach where you look at everything inside and out and ask yourself, is this going to support everybody? Is this addressing and giving space for everybody's needs to be met? Being mindful of how it's going to be received, being mindful of the firsthand experiences that other people might have. But it's really important to keep in the back of our mind this understanding that we realize there's trauma, we recognize what the signs are, that we're responding in a way that's positive and supportive without re-traumatizing. Some of the ways that have been helpful, and I find really positive for me, and we share with our staff sometimes, are these quotes on the screen. I'm going to read them, but feel free to share if one of them speaks to you or if you have others. But students with childhood trauma don't have faulty brains. They have minds that have been designed in a threatening environment that help them survive. It's not you against the child or you against the person. It's you and this child, this person, against their history. It's not a personal attack on you. Trauma comes back as a reaction, not a memory. And then imagine what could happen if, instead of asking what's wrong with you, we ask what happened to you. And so these are things I think that are just helpful, sometimes even motivational, to remind us that what's going on with an individual, it's not about us. It's honestly probably not even really what just happened, but it's what they're experiencing in the moment because of the trauma. And so how do we create that space? How do we actually create the culture? And the reality is, creating systemic change is really hard. Not hard because it's impossible, but hard because it takes time, and hard because it's not something that you can do by yourself. There's not a step-by-step plan. There's not follow these 5 guidelines and check the boxes. It's also not the reality that even if you go through all the hard work, the outcome is going to be exactly what you hoped for. So when you think about, or when I think about anyway, a systems approach, I think about what's going on. What am I seeing? What am I hearing? What are people telling me that they're experiencing? What's that event that's happening? And then is that the event? Is that the experience that I want for the students, for my staff, for my families? And then I think about, well, maybe not. Maybe I want something different. Maybe I want them to have something more, something better. And so I start thinking about, well, what questions do I need to ask? What patterns are happening? What are the trends? Then we dig a little bit deeper, and it's what are the structures? What are the practices? What are we doing that might be contributing to what we want, or maybe pulling away from what we want? And I always have to also remind myself that this work can't be done alone. And so having to establish maybe some new guidelines and pulling in different people to provide feedback and insight, and who are my stakeholders. And stakeholders are not just people in leadership positions by title, but stakeholders are also your staff, your parents, your students, people who are both maybe being receiving of services, but people who you can collaborate with outside of your organization to create some really holistic approaches. But once you've taken the first step to recognize, I want something different or something better, I want to help our students, our families, our communities thrive, you start asking yourself, okay, who needs to be on my team? Who has the knowledge, the experience, the connections? And then from there, as a team, you have to wrestle with, what change do you want to see? Why do I want to see it? What steps need to happen for the change to occur? And when do I want to see those things happen by? And then how will we know that that change has occurred? And if you think about it, pretend you went to sleep tonight, and while you were sleeping, someone may wave that magic wand over your head and in your dreams, and you woke up and you went to your school or to your place of work or to your church the next day, and something magical happened. Like you woke up and you walked in and it felt different. You walked into what you hope for. Think about, what did you notice? What was different? What did you see? What did you hear? What did you experience? Because those are the things that you want to figure out how to make happen. How do you identify what those are? And how do you evaluate and measure that that's what's coming to fruition? So I know I said there's not really a framework, but there is a really great tool. It's the Practical Guide for Implementing a Trauma-Informed Approach. And it was put out, there's a new updated one that came out this year, and it's linked down in the bottom of this slide. But they break down to some categories. The first is governance and leadership. And so full support, full transparency on decision-making, seeking feedback from stakeholders, and modeling the work is really important. Training and workforce development. So how are we interviewing, onboarding new hires? Is our holistic training approach so that our teams have the frameworks, the practical skills, the tools, and that there's also ongoing supervision and coaching support? Are we creating cross-sector collaboration? So do we have interdisciplinary teams? Are we bringing in community-based organizations to support and come alongside in their expertise? How are we also equipping our communities with trainings and learning opportunities? Financing, the reality, my husband likes to say this a lot, where you spend your money is also where you place your value. And so thinking about, if we're wanting to create cultures that are supportive, are we putting our money and our finances in that direction? Think about the physical environment. What's the lighting? What's the noise? What's the spaces? What's on our walls? What does that say about our culture and our environment? Think about engagement and involvement. Do we have key relationships? How are we building them? How are we sustaining them? How are we connecting with people? What's our screening, assessment, and treatment service practices? How are we helping to identify the needs and intentional supports? Progress monitoring and quality assurance. Again, you have to know where you're starting, you have to know where you're going, and be consistent in measuring What are your policies saying about your practices, and ensuring that they're policies that are supporting a culture of inclusivity and a culture of unconditional care, and then always evaluating and seeking feedback. So what I'd like to do with this last little bit, I have 4 case studies, 4 things that we've actually seen and experienced, and kind of walk through those and give examples of how the practices that have been put in place in some areas have been really helpful for students, but also really helpful and supportive for the staff and teams on campus. So the first one I'll share is a story about Marcus. Marcus is a 6th grader. In elementary school, he did really well academically. He had a really great group of friends. But over the summer, Marcus's family of 6 moved into a hotel. His father lost his job, and they couldn't maintain their home, so they became homeless. Marcus was excited to return back to school. He was excited for a sense of normalcy. And for about the past 2 months, he's been getting off the bus and going in the cafeteria for breakfast. It's been great to eat with friends and hang out with friends, but there's just come a point now where he's tired and life feels chaotic. And by the time he gets to 3rd period, he is just wishing for some silence. So his teacher has started to notice these constant outbursts and frustration with peers and disengaging in school. And they've even started to notice that his grades have dropped. And what I loved about this case study was watching how not only his teachers, but the whole school kind of looked at, how do we adjust? Because it can't just be this one student who's experiencing these feelings. He's experiencing them because he's living in a small hotel room with 6 people, and that makes sense. But he's not the only one. So they looked at the physical environment. They looked at how they're engaging and involving with students and with each other. And then they also looked at the progress and monitoring side. So they walked through the school one day just in the shoes of a student. So if you're a student, what does it look like to walk through the halls? What does it feel like? What does it sound like? They looked for some feedback. They also considered, how do we create diverse spaces? So instead of having every kid come into the cafeteria, could we provide options where if you want to come into the cafeteria because you want to socialize and you're okay with the loud noise, great. Or do you want to come into the library because you just need some quiet? You want to be by yourself. How do we create those spaces? They also looked at lighting and the inviting spaces in the classroom. They looked at how do they provide ways for students to ask for what they need. Do they need a break? Do they need a quiet space? Do they need more engagement because they're feeling left out or alone? And they also worked to implement some designated quiet times during the school day. 10 minutes after all the lunch periods are over, it's just quiet. So students can take a breath. Teachers, honestly, could take a breath. When they looked at engagement and involvement, they looked at how are we greeting kids when they come in? How are we checking in with them? They looked at who can they collaborate with in the community that has experience with homeless populations and services. They also wanted to make sure they're providing all of their information and resources in ways that are accessible, whether it's a language barrier, an internet or connectivity barrier, but they reevaluated those. They also created a check-in and check-out system where those students that they identified that were high risk or had a lot of traumatic experiences, who are their one-on-one mentors? Who are people that in the campus, those caring adults that are not their teachers, but can check in on them each day? Hey, how's it going? How was lunch? How was your test? And so being very intentional that those students know they had a safe place, that their basic needs are going to be met, and that they knew that they weren't alone in those experiences. Another example is Nicole. She's a spunky little 4th grader. She's not afraid of anything at all. She lives with her mom, who works 2 jobs, and most times after school, Nicole's going home. by herself, but her mom and her worked out these rules where here's the snacks you can get if you're hungry. Here's who you call if something happens. Here's the neighbor you go to. But sometimes, snacks are not enough. Sometimes you get hungry. And so every so often when Nicole is in class, she gets hangry and she lashes out at her teacher. And one day her teacher just had enough. And she's like, go. Like, I cannot handle you. And she sent her to the principal's office. What I love about this, I always remember when I first met this principal because she was running around. She was running around her campus, and she always had her purse on every time I saw her. And finally, about our third interaction, we asked, "Why do you always have your purse? Or like we always catching you on your way in, your way out?" She goes, "No, my purse is always on me because my purse has snacks, my purse has stickers, my purse has water bottles." And she told me this story about Nicole, and she said, I want my students to know that their basic needs are going to be met. And I loved it because that to me was a great example of the principal and the leadership being fully bought in and fully modeling practical ways to do the work. Principal also shared they're really intentional that whole school year about building in their workforce development and training. They had a monthly plan for doing topics around poverty, around food insecurity, about health determinants and factors that impact a student's academic performance. That whole idea of first you have to kind of meet the Maslow's hierarchy of needs before you can do Bloom's taxonomy and really help kids learn and grow academically. She also built in time for their staff meetings so that teachers could decompress with each other and share the hard stories that they're hearing. She recognized early on that if her teachers are meeting the basic needs of kids, 9 times out of 10, they're going to get overwhelmed with hearing the constant stories of, I have no food, I have no lights, I don't know what's going to happen, this happened, this happened. And so she built in time for them to decompress with each other. And then she also allocated funding in her budget for those snacks. She didn't want to expect her teachers to pay for or buy them. And so she allocated some of her dollars and she worked that out in her budget and also worked out funding for some of the training. So applying some of those areas of implementation just at the basic level to address hunger and creating that space for kids was really great to see. Another example was Alex. He was an 11th grader. Pretty much his whole secondary career had been identified as this defiant kid, outspoken, didn't really want to do what his teachers were asking all the time. But over the course of his high school career, he'd been in and out of in-school suspension a lot. He'd been to the alternative program multiple times for getting into fights. His fights typically occurred, though, because he was feeling discriminated against or called out on because of how he identified in his ethnicity and race and his sexual orientation. And he quite frankly got tired of just talking to people about it and telling people, hey, this is happening. When's it going to stop? What's going to happen? So he would fight. And during his most recent incident at the time, they ended up calling the school resource officer and they ended up walking him off campus and taking him away. And that was pretty hard to watch. But in that process, he also started sharing, like, why am I here? What's the purpose? And had those thoughts of self-harm and suicide ideation. In this scenario, though, this is one of those where I wish I would have seen it a little differently in implementation, but it was something that the school came back and tried to figure out, okay, we've got to do this differently. We've got to do this better. So I loved their honest introspection of themselves. But they looked at who needs to have a seat at the table. We have our school counselors. We have experience from our teachers and our admin, but who else needs to be invited to the table? Do we need to invite law enforcement? Do we need to invite other mental health organizations or professionals to help us think through what are we missing? What are we not seeing so that all of our students feel they have this environment that they can be cared for? They also took a look at the systems that they have in place for screening and for identifying students who might be high need early on. They also considered the reintegration plan. So if a student comes back from a treatment facility or an alternative education program, instead of just putting them right back into the environment that was the stressor or the contributor to what sent them away in the first place, how do we reintegrate them back in? How do we have conversations with them, conversations with parents, conversations with teachers, so that everybody at the table knows we want the student to be successful, and here's the plan of how we can do that, and here's the resources the student has at their disposal to say, this isn't working, or this is happening, or I need help in a different way. And they also took a look at their policies around bullying and around identifying, to make sure that, again, there wasn't something they were missing, or that their policy wasn't re-traumatizing. They even asked the question, how many times does a student have to report what may or may not be perceived as bullying before we take a step to say, let's have a conversation? And so, again, lots of different ways. These aren't the only ways to look at how to implement a trauma-informed culture, but these are just some examples. And then the last one I'll share is really about a teacher. And so Miss Thompson, she'd been a teacher for 9 years. She's been an amazing teacher. She saw all different types of grades. And this most recent year, she was going back and teaching second grade for the first time at a new school. Very excited for a change of scenery, new classroom, new experiences. But by the end of the first semester, she'd already made multiple CPS reports for neglect. She had run out of all of the snacks in her drawer because kids were coming and saying they were hungry. She'd even started to hear some of her students talk disparagingly about themselves and about being in school. Why am I here? This doesn't make sense. This is pointless. This is worthless. And so each day it got a little bit harder and a little bit more exhausting to get up and come to work. She found she didn't want to do some of the things that she enjoyed sometimes with her families. And that was really hard for her. In this scenario, being able to have a space where she could share that with her campus leadership, then they begin to think about ways to reshape their training and workforce development, looking at ways to provide compassion fatigue counseling, making sure that all of their staff knew about their EAP programs and reminders about how to access those counseling services through their health insurance. They discussed what it would look like to provide mental health days. So was that providing a substitute? Was that providing extra PTO? They also talked about how do we make sure that these fatigues and these feelings don't transpire to other teachers, but also for volunteers and community partners, recognizing that there was more to their team than just the teachers. They looked at how to create some engagement, some meaningful engagement for their teachers as staff, and created morning meditation opportunities where their staff could just get together every Wednesday in the gym and have some meditation, whether it was quiet time or yoga or stretching, but time to be together to start their day. They also looked to their PTA staff, PTA, to really think about how to support their staff. What were their things that they needed? What were things that the PTA could come alongside and encourage and refresh their staff on? And then also looked at how to build support groups for new teachers and first-year teachers, so they know what they were experiencing. They weren't alone. They probably were going to feel a little tired, but let's talk through it with a veteran. And then finally, looking at how do we look to see what we're doing is actually making an impact. And so that progress monitoring, they went back and looked at how often from year 1 to year 2, their PTO time was taken. What was their turnover data and retention data like for their staff? And they looked for feedback from their staff. And so all of, I know that's probably a quick run through of some case studies, but those are just examples of things that if you're looking to create that culture and that environment where everybody feels that their needs are going to be met, you can take some examples of it. And again, these are just some simple examples, but I do want to reiterate that when you're creating a culture, it's not a sprint. It is a marathon that you end up running like a relay. So you can't do it by yourself and you can't do it quickly, but it is a long haul that you do across with a team, and you're passing the baton off every so often with people who have experience and who has insights in how to help reach that next goal of creating that inclusive culture of support. And Lindsay, that's all I have.
Thank you, Tasha, so much. We'll open the floor for questions now. Feel free to type those in the chat or unmute yourself and ask any questions of Tasha specific to shifting your organizational culture to a trauma-informed place, whether that be for clients or staff. So please, any questions?
I would like to suggest that perhaps maybe a solution to alleviate the shortage of food and to help out those students with the lowest socioeconomic level is perhaps to do some community network and see any food banks that are willing to donate food, or local supermarkets. Local supermarkets, they are more than willing to do that because it's a tax write-off. So if it takes some coordinations and to do some social work, and perhaps maybe the situation could be alleviated. We're lucky that here in Miami-Dade County, all of the students, they have free breakfast and lunch, regardless of their economic status. So that's a big plus. But perhaps, maybe if you guys do some network and get some volunteers to do donations, or to provide information where there are food drives. So perhaps the parents, they can go, and secure some groceries. Perhaps maybe some of the parents, they don't know that they may qualify for certain benefits, but they're not aware. And it takes, yes. So maybe that's a solution to alleviate the problem.
Yeah, no, it's a great example. Don't try to recreate the wheel. Partner and network and leverage your resources.
Yes.
Tasha, when we think about, I'm sorry, Joseph.
When we think that it was a great presentation. Thank you.
Yes. Oh, good. Wonderful. I'm glad you enjoyed it. When we think about systemic change and shifting organizational culture, oftentimes we come up against bureaucratic systems that make change challenging. Do you have any suggestions for folks that want to, implement and work towards change to craft trauma-informed organizational settings, but potentially that's really challenging in systems that we work in?
Yeah.
Hi. Sorry, can you hear me?
Yes.
My name is Sandra. I'm from Canada. And when my son was in high school, they had like CYWs working at the high schools because dropout is a huge portion. It's so related to high school, many dropouts, right? So some of the measures that our school systems have taken is that we have CYWs at the schools to assist the teachers and the students that need their assistance, somebody that's advocating for the children themselves. They also have open classrooms where, how you would have like a spare, I think, is that what you call it there too, like a spare where they don't have classes. So they have these classrooms open where the teachers actually help the children with whatever subjects they may be having difficulty with. And so they get assistance in that way, because if they don't feel they're at capacity with other students, that's one of the likelihoods of dropping out. Also having committees around social events, which I know that I don't know, the things I hear about the states, how things are reshaping, and with people, and depending with the politics, how things are swaying back and forth. But they actually have the students that have coalition with groups with people that are LGBTQ students, right? So they can talk about those things in a safe place where they don't have to share with the whole school, but they have their safe place and they know they can talk about it and experience other people that are going through the same things, or awareness to different cultures and beliefs, and so they have access to all of those things in classroom settings where they're supervised by either a CYW or a teacher who volunteers, or a teacher who happens to have that spare at that time. But it starts with the opening of the community itself, and they're by any means not doing it free, but just doing it, probably charging it probably as what it would be to be teaching in that classroom setting, but you're just available for tutoring. Thank you.
Those are great ideas.
Yeah, I appreciate that insight too. And Tasha, I actually think that speaker, who I couldn't actually identify on the screen, so I'm sorry I don't know your name, speaker, but really set the stage too for the lead into what do we do specifically in Texas too when we run up against bureaucratic systems that maybe don't have some of the supports that others do. Like what would you suggest?
Yeah. So that's a hard one, but what I would say is expect that you're going to run into it. Like, when grieving just doesn't happen with the loss, like when someone dies or like through divorce, but grieving also happens when something that once was is being asked to change. And so sometimes being able to help people see opportunity. So share the stories. Make sure that you're talking with people about, hey, this is what it is right now, but here's what it could be. Here's the implications. Like there's some good, there's some not so good, but being open to that dialogue and understanding that through that dialogue, people are going to, they're going to push back. They're going to ask questions. They might agree. They might not agree. But part of that's the process of seeing what can be changed, being willing to walk alongside and walk with people through that process of change, and whether it's a grieving or a loss or excitement for that. And then share stories, share stats. Don't give up. Try opportunities. Give them examples of where it did work well.
Thank you, Tasha. Any other questions for Tasha? Okay. I am hoping that we can give you 12 whole minutes back in your day. Really quickly before we go, we want to thank all of our speakers who joined us today. We want to thank you all for joining us today from apparently around the world, which is very exciting. So we're so glad that you were here and that our speakers shared their knowledge. Before we end our workshop, we'd like to take a moment to talk about the evaluation that you're going to complete. There is a QR code link on your screen. It's also about to be put in the chat box for you to complete this evaluation. Please complete that. That's how you will get your CEUs also. So make note that the email you used when filling out your sign-in today will also have this link sent to that email as well this afternoon at some point. But if you want to go ahead and complete that evaluation right now, you can absolutely do that. Your input and feedback on that evaluation is really vital for us as we craft future wellness workshops. So please provide insight on presentations you'd be keen to learn about, on tools that would be really helpful for us to develop for you, any kind of thing that you'd like to see in the future. We would be really, really thankful for you to provide information on that in your evaluation form as well. Today's topic was the first in a 3-part series, so we hope that you will come back for the next 2 sessions. Our next training will be on October 27th, so go ahead and mark your calendars for that now, and there will be more information about that. We take your feedback really seriously, and we're so grateful for everyone who chose to attend today. How can we view this again or share with someone? This will be uploaded to the website, so I think that we can probably email that out as well, so you can find where it is located. Please feel free to stay on. We'll keep the Zoom session open for a few minutes for folks to network, should you want to stay on and do that. And then please feel free to share any information about your organization or anything that you'd like people to know as far as resources that are available in the chat as well. Thank y'all so much for spending your time with us today, for engaging in this learning opportunity, and for being change makers in your communities and organizations. We're so grateful that y'all are here. Thank you. Yes, the next training will be on October 27th, and that will be about substance use and cultivating strategies for children and adolescents. And then the third part, I don't know the date and time for that one, will revolve around anxiety and supporting pieces.
Bye, guys.
Bye.
Bye.